Introduce Dr. Kelly Andrzejewski, and she's an instructor in the Department of Neurology at the University, was an instructor at the Department of Neurology at the University of Rochester, educated. What's that?
I'm currently a clinical assistant professor at University of Buffalo.
True, very true. I'll let her take over. She knows
Okay.
what she's saying.
So I previously was at University of Rochester, but I just want to make it clear I'm now a clinical assistant professor at University of Buffalo, so I'm seeing patients here in Buffalo. Is that better? Okay, I'll use my deep voice along with hopefully the microphone can be increased. Is that it? Okay, I'll use my deep voice. My patients know how I have my girly voice and my deep voice, so I'll use my best. So I said I'm a clinical assistant professor at University of Buffalo now. So I was formerly at University of Rochester. Okay, so today I'm actually going to talk to you guys about the role of deep brain stimulation in Parkinson's disease. Just got to get the little thing here. Okay. Can you help me? No, it's back. Big green button. Okay, there we go. It says a couple different forward, backwards, and I'm not quite sure which button for sure. Okay, so I know Dr. Hinson did a really good job already talking to you about a lot of the features of Parkinson's disease. So again, just a quick abbreviation. The symptoms of Parkinson's disease are due to a loss of the chemical called dopamine in the brain. The main motor symptoms, Dr. Hinson talked about the non-motor symptoms. The main motor symptoms are tremor, which does not occur in everyone, but in many patients. People can also have slowness of movement, which we refer to as bradykinesia, if you ever hear that word in the literature. People can also have stiffness and rigidity, or like stiffness and a ratchetingness to some of their, at least in the arm movements. And people can also have difficulty in walking. They can have shuffling, as well as just the slowness associated with Parkinson's can also make it more difficult to walk. So I'm one of the deep brain stimulation specialists here in the Buffalo area now. So to tell you a little bit about deep brain stimulation, it's used typically to treat some of the classic motor symptoms of Parkinson's that I just mentioned. It's not going to be used to treat symptoms like constipation, hallucinations, depression. So the other things that deep brain stimulation can actually help with are dyskinesias. So if your doctor tries to do their best to optimize your medication to try to reduce dyskinesias, which are in the involuntary kind of twitchy movements that sometimes can be a complication of levodopa and other Parkinson's medications, deep brain stimulation might also help with the dyskinesias. As I just mentioned, non-motor symptoms that Dr. Hinson talked about in most cases do not improve with deep brain stimulation. So what exactly is the deep brain stimulation? We also call it DBS for short. So if I use that, that's what I'm referring to. So essentially we have a battery or batteries, depending on if we do one side or both sides of deep brain stimulation surgery. You have a battery that's kind of like a pacemaker that will get installed almost, implanted right beneath your collarbone. It's connected to a wire that is through a little extension wire is then connected to a permanent, what we call a lead that goes into your brain. There's ever-changing technology, but the typical lead that's been around for about 20 years, produced by a company called Medtronic, has 4 little contacts on it. So you can see a little contacts where it says electrode on there. Those contacts we put electricity through, and that allows us to help control your movement symptoms or motor symptoms. So as I just mentioned, the DBS system is composed of the lead. So the top little picture there where it's got 4 little metal contacts on it, that's the lead that gets put in your brain. The extension wire connects that lead down to the batteries. And those are, you see on the bottom there, what we call the IPG or implantable pulse generator, which it's just easier to call a battery, that helps deliver that electricity. There's a picture of that, and that's what actually gets installed underneath your collarbone or placed. So as I said, what are some of the reasons for DBS surgery? So as I said, it treats the motor symptoms of Parkinson's. So when people are having a lot of off time, meaning difficulty, even when we try to optimize people's medication, if they're still having difficulty with slowness when the medication isn't helping enough or they get sudden off time, DBS can help with that. DBS can also help with tremor. In some patients, tremor does improve with medications like levodopa or the different dopamine agonist medications. Other times it doesn't. And especially in those people that it doesn't, even if the medication does not help with your tremor, oftentimes DBS can be very effective at helping reduce your tremor or completely eliminate it nearly. People also have a lot of up and down in how effective their medication is. Maybe they're taking their carbidopa levodopa every 2 hours and then still have either a combination of dyskinesias as their medication is peaking or wearing off of their medication frequently. If alterations or changes in your Parkinson's medications don't improve those symptoms, then a lot of times DBS can be very effective. It kind of helps smooth out those hills and valleys that we see with your medication changes. Also, as I mentioned, people that have the involuntary kind of twitchy movements or rocking movements called dyskinesias, that can also be very effectively controlled with, or at least reduced with DBS. So this is an example, so assuming the video works, of a patient with their medications on board before they have deep brain stimulation. So can you take the mouse and kind of, there we go. Hopefully it'll play. Looks like, yeah, there we go. So we don't have sound here, but you can kind of see the gentleman's holding his hands out. And then his tremor, a lot of times when you do that, eventually the tremor will kind of come out. So just give him a second. It should be, assuming they didn't jump through an extra video here. Okay, this must have been the one after surgery. So I don't know if we jumped ahead a little bit, but you can go ahead and forward on. Okay, yeah, I think we jumped ahead one slide, so I apologize because the person had a tremor before, so that was the post-DBS. So who are people that don't qualify for DBS? These are typically people that have what we sometimes call Parkinsonism. So that can be like an atypical form, sometimes called PSP or progressive supranuclear palsy, or another condition called MSA or multiple systems atrophy. People that also have dementia or significant cognitive impairment can also have difficulty and are usually not good candidates for deep brain stimulation because it can actually sometimes worsen their cognition a little bit or their thinking. People that have significant issues or disabilities, even when their medications are on, may also not be the best. And sometimes people just have a medical condition, which we can't really go into all the details. There's a lot of different circumstances that may make the surgeon and myself say, might not be the best candidate. Maybe we should stick to medications. Okay, so assuming someone does qualify for deep brain stimulation and we go through with the surgery, after all of the little mechanical parts are implanted, the patient will come in and we'll turn their stimulator on for the first time. So here's an example of Pat here turning on someone's stimulator with one of our patients. During that initial trial process, we'll test each of the 4 little contacts on that wire that we put in your brain and to see which ones may produce the best benefit. Sometimes DBS can also cause side effects. So we place the lead as perfectly as it can, but it's not perfect. So sometimes if we go too high on the stimulation, that can also cause kind of like a pulling or kind of a numbness or tingling sensation. So that's why we need to check each of those electrodes to see which, if any of them cause that, we need to make sure we don't set the settings too high. So based on after Pat and I check each of those little contacts, we decide which is the best one that might provide not only the best benefit, but also help with your trying to avoid any kind of side effects, because we don't want that. So what are some of the risks of deep brain stimulation surgery? For some people, they might actually have a slight worsening. Anytime we do a surgery, there's a risk that you may have side effects. Some of these may include a brain bleed or a hemorrhage. It can occur in about 2%. It may be a very small bleed that sometimes we don't even detect, but for some people it can be worse and sometimes even lead to death. Dr. Plunkett and I don't put wires in people. We don't think they're a good candidate. It's for people that we feel are the best candidate. Sometimes, like I mentioned earlier, if people already have difficulty with thinking and memory, and even if they're doing pretty good to begin with, sometimes we can still have a little bit of slowing in your thinking and memory after the surgery. Also, sometimes we have risks of just complications like infection associated with we're putting a foreign substance of different metal components into your body, so there's always a risk of infection. Sometimes we also have breakage in the DBS hardware or malfunction. That's much less common than it was when we first started out. And DBS has actually been around for about 20 years now. It was first approved in 1997. So we kind of hit a good new mark this year. Okay. So as I mentioned earlier, briefly, that deep brain stimulation can also lead to death in a very small number of people or increase the risk of seizure. And in some people, there's even been a reported increase of suicide. It's very uncommon, but we still have to mention it. Here is just a quick graph that kind of shows that people where it says DBS and BMT means best medical therapy. So people that had best medical therapy means your doctor kind of adjusting your medications to make your quality of life as best as they can versus best medical therapy plus DBS. People with DBS had a much better quality of life. They were able to do some of their basic activities. The PDQ-39 there is really a disease quality of life measure kind of scoring system that sometimes we have people do. In some cases, depending on the brain target Dr. Plunkett and I choose, or if you have your hardware installed somewhere else, sometimes we can reduce people's medications, their Parkinson's medications a little bit. I always tell my patients that is not the goal of surgery, though. And some people we're not able to do that, or we can only do it a little bit. But some people we are able to lower the medication, but rarely are we able to completely eliminate it. That's not usually something that happens, and we still at least you require some medication. So this again is a little bit, we talked about that word called dyskinesia, the involuntary kind of twitchy or rocking movements. Here you can see that at 6 months after DBS, people had a significant reduction in dyskinesias. So if you'd like to learn a little bit more about DBS, my nurse Pat that is involved in kind of the coordinator for deep brain stimulation, we have seminars about every 3 months or so. So our next one is actually coming up in August. If you ever have any questions about deep brain stimulation, you can also contact Pat at our number up here, which I think that Chris can make available later. And so our next seminar is on August 7th. So we just had one. So since it's about every 3 months, we are on a short hiatus, but Pat can always, or if we get enough interest, we can always consider adding one on. But otherwise, that'll be the next planned seminar, and it's out at our Orchard Park neurosurgery location where I also see patients. Okay, so thank you very much, everyone. If you have any questions later, we can address them in part of the kind of group question, because we've got a lot of talks to keep on going today, right? Okay, thank you, Chris.